Welcome back to our session 2 of the Nafld Care 2022 Innovations webinar here. And I'm very glad to have you all back. We're going to start right into the second session. It's my particular pleasure and honor to introduce to you my co-chair for this second session. This is Professor Cyril Kasi. Professor Kasi is located at the University in Lyon of France. She's a professor of nutrition and an endocrinologist, diabetologist at the respective university. She spent time at UCSD during her training and got particularly interested in non-invasive tests for non-alcoholic fatty liver disease and has been working in the field since then. And it's a true pleasure and honor to have you here this evening, Cyril. Glad to chair this session with you.
Thank you, John. Thank you for this introduction. I'm very pleased to participate in this webinar regarding innovation in Nafld cares. We will have a very exciting roundtable discussion, but just before that, it is my honor to introduce you with the speaker of this session. Professor Emmanuel Tsukatsis is a professor of hepatology, a consultant hepatologist at UCL Institute for Liver and Digestive Health at the Royal Free Hospital in London. He is the head of the Center of Metabolic Liver Disease and also the chair of the EASL Scientific Committee and member of the EASL Governing Board. I think it doesn't need any further introduction. Professor Tsukatsis is well known for his specialist multidisciplinary service in Nafld at the Royal Free Hospital, integrated with an active research program. And tonight will share with us his view of defining comprehensive models of care of Nafld. Please, Professor Tsukatsis.
So in the next few minutes, I will be talking about comprehensive models of care for Nafld, and this will inform our discussion following this presentation. Although Nafld is prevalent in 25% of the general adult population, there is a huge disparity between this estimated prevalence and the actual diagnosis and recording in primary care. This comes from 4 large GP databases in 4 European countries. And as you can see, the coding of Nafld starts from as low as 0.2%, and the highest percentage is 2.6%. So there is a lot to be achieved still in recognizing the disease. Then this comes from Jeff Lazarus. It reviewed the Nafld policy in 102 countries around the world, and it calculated a preparedness index based on the availability of national Nafld policies, guidelines, civil awareness, epidemiology and data, Nafld detection, and Nafld management. And the results were very, very discouraging. The highest achieved score was just 42%, and a third of the countries scored 0. The part of the problem is that there are no formal screening strategies for Nafld, and the diagnosis is still incidental, based on findings of steatosis on ultrasound or of findings of abnormal liver blood tests performed for another region. And the referral to liver specialists are not standardized and are very variable. And even the assessment of Nafld varies a lot. This is from UK data, but they still apply today. And you can see, for instance, that in primary care, only a small minority performs the FIB-4 score. No one does fibroscans, and you can see that AST is routinely performed in just a third of the cases. There are a lot of challenges that include low awareness, variability in clinical care. The guidelines that are produced by hepatologists are only visible in the hepatology community, and comprehensive care models are lacking. This was an exercise led by Jeff Lazarus on how comprehensive Nafld care models should look like. And there were 4 key questions that were asked. What services are provided? Where are the services provided? Who is providing the services? And how are the services integrated? There was a systematic review, and there were some key recommendations, 8 key recommendations that we can further talk about. Regarding what the recommendations are: to develop guidance on screening and testing with non-invasive tests, to establish patient-centered pathways tailored to the disease stage, to outline actions to prevent disease progression, and to develop guidance on treatment strategies related to disease stage. Regarding where, this would be to articulate the roles of and interactions between primary, secondary, and tertiary care providers, and establish where the co-location of services for the treatment of Nafld and common comorbidities is feasible. Regarding the who, to define the composition and structure of the multidisciplinary team responsible for managing patients with Nafld. And regarding how, to establish systems for coordinating and integrating care across the healthcare system. I will show you just a brief example of how we are doing this in London. And this is the Camden and Islington pathway. That is a referral pathway from primary to secondary care that consists of risk stratification at the primary care level with non-invasive fibrosis test, and then detailed instructions on how to manage disease in primary care and who to refer to specialists, to liver specialists. And you can see that by systemically using this pathway, we increase the detection of advanced fibrosis 4-fold. And then regarding where and how to treat, you can see that we have a multidisciplinary Nafld clinic that consists of a liver dietitian, a chemical pathologist for the cardiovascular risk, a specialist nurse, and then same-day non-invasive fibrosis assessment. And by having this multidisciplinary clinic on top of treatment for the liver comorbidities, there is additional treatment in 40% of the patients for their metabolic comorbidities. And this results not only in improvement of clinical liver outcomes, but also of an improvement in cardiovascular outcomes. And you can see indicatively that there is a mean Q-risk 3 score reduction of 3.4% and a mean gain of 6.1 heart attack and stroke-free years. In conclusion, and as a starting point for our discussion, Nafld is under-recognized in the wider medical field outside of pathology. Comprehensive care models are essential. Effective pathways need to be co-designed with primary care. And finally, these care models should be multi-morbidity, patient-centered care models. Thank you very much, and we will move now to the discussion.
Thank you very much, Professor Tsukatsis, for this very nice talk that really shows us how we need to integrate multidisciplinary approach for the treatment and detection and screening of the patient with Nafld. I would like to thank all the speakers from the session one to join us. Thank you for joining us for this roundtable. We hope we will have a very nice interactive discussion. You can also please feel free to ask any question you would like on the chat to any of our experts in the field. I would like to start with one question for all the panelists, and especially directed towards Professor Tsukatsis. You have shown us the example of your clinical pathway, and we have also talked about in the previous session that it's absolutely essential to bring awareness of the disease, and probably this is the lack of awareness, as stated by Professor Kusi, that's also impede the screening for advanced fibrosis in patients at high risk. So how do you think we should improve and bring awareness, especially when you're working with primary care physician, endocrinologists, diabetologists around your clinic, to bring awareness to the physician, but also probably to the patient, I think?
Thank you for the question. I think that this is a work in progress. This will be achieved with time. I don't think it can be achievable within a month. But we need to start this dialogue with other specialties. We need to involve them in the care and management of patients. We need to create educational sessions for them. When we introduced our GP pathway, we sat down with our commissioners, with our GP commissioners. We discussed the pathway. For instance, we chose ELF over FibroScan based on what they preferred and what they suggested. And then I spent, and I'm still spending evenings and educational events for the GPs, where I go to them and I talk to them about Nafld, I talk to them about liver disease, and this is an ongoing process. And of course, it's also in a medical society level. What Kenneth Cushing mentioned, for instance, the guidelines for endocrinologists. This is very, very important, but it will take time. It's not something that will be done in a month.
Thank you, Manolis. And I agree. I think to define these pathways moving forward is very important for the field to actually provide good care. And I think the examples from the UK, I'm always a little jealous because we don't have those structured systems in Germany yet, show that by doing these referrals, as you've shown, you can actually select on certain patients that are at risk. I'd like to hand on that question actually to Robert and ask him, from the patient perspective, how can the patient support this development? Maybe asking their physicians about structured pathways, or maybe just how do you perceive those pathways as a patient?
Okay, thank you. And again, another great question. So I think I'll take them in reverse order. I think the pathways are really, really important. And one of the innovations, and it chokes me to credit the US when it happens, but there is a US NASH action plan that's in place, and it's there's already a scorecard where we can look at whether or not certain things have been achieved. And I think the clinical care pathways are really, really important tool to be used within that action plan. So the fact that we're creating more structure is incredibly important. I think when it comes to reaching patients, when it comes to empowering patients, I think each of us in this room have a part to play. And it's not only in our direct conversations with patients, but this is where signposting becomes really important. And one of the last slides that I had was, the second most important thing you can do is join a patient support organization, because we do see each other, we understand each other, and we can give each other the language that's needed to have an engaged conversation. Sometimes it's easy to forget. When you look around the room, we see all over every screen bastions of best practice. And that isn't always the everyday experience. So sometimes it's up to us to empower patients, to give them the language they need, and sometimes the confidence to ask the questions, to then engage with the care pathways. So I think each of us has a role within that. And one of the most important parts is to help empower the patients and to make sure they are part of our patient community or our patient population.
Okay, thank you. And I think, having two endocrinologists on this board, of course, you, Cyril, and Kenneth, maybe from my hepatologist perspective, I'll just say, what can I do to inform my colleagues on this situation? What would they need from me in order to provide better care to their patient? Because our pathways often will start in the endocrinologist's department, I think. So maybe Kenneth, first over to you. What do the endocrinologists need from us to support these pathways?
Well, I think what we need is better education and better communication. I think in most of the world, I see that again, specialties work somehow in silos, largely because they're busy. But I've seen that when we begin talking more, for example, I've had several hepatologists from different universities communicate with endocrinologists and put like FibroScans in their clinic, largely because of clinical trials. But that has been an eye-opener to many endocrinologists. So I'm hopeful about that. Sometimes there are some that are still in disbelief on my end, but I think that there's a willingness to do it. It just, there are many barriers that are beyond, that are structural, but that doesn't mean that we cannot do it. I mean, I remember, I'm old enough to remember that when we began screening for diabetic nephropathy, a lot easier to collect a urine sample than an imaging test. But again, over years, the rate of diabetic nephropathy has dropped markedly, despite the fact that obesity and diabetes have grown. So it is doable. But again, as was mentioned earlier, it's not going to happen overnight. But I think in the near term, hepatologists should be like the godfathers, educating the rest of the people in the team of this problem and getting practical, and facilitating this communication. How do you see it? How is it in your institution?
Well, yeah, I totally agree with you. I think it's a lot of effort that need to put in that. And as said also, Emmanuel Tsukatsis, we need to work together, and it takes a lot of time to talk with the hepatologists from your area, from clinics around you. And it's the same when hepatologists come to us and explain as well how to use the different diagnostic tool and to screen for advanced fibrosis, and then we agree on a specific pathway. No matter what is it? I mean, for example, in France, we don't have ELF, but we are using other first-line tests, and we agree on the one we are going to use. The major thing also is that since we have started to use transient elastography in the endocrinologist clinic, the pathway has really improved. We do not overwhelm the system. There's no over-referral in the hepatologists. Hepatologists are more happy to deal with patients with advanced fibrosis, and we take care and we deal with the patient with low liver stiffness that obviously doesn't have any indirect marker of fibrosis, and they just need, to keep on managing their diet, improving diabetes control. So the key thing is putting the tools in the good hands, educate the physician and diabetologist to use them, and agree on a pathway. And I think this takes some time. We are seeing a lot of guidelines that are moving. There's a new guidelines for EASL that really need to be to bring awareness to the endocrinologists that we should use two-step screening, and we are getting there. I think it's not that the endocrinologists are not willing to do it. They just need to be more educated about how to do it, because as you said in your talk, it can be pretty overwhelming to deal with all the different complications and add on top of that, well, we need to talk of your liver now. So we need to be able to use this test very easily to address the good patient to the hepatologist.
Good points.
I think we also could ask the same question to the hepatologist. When we refer to you some patient, what do you, or maybe sometimes it's the different hepatologists send us patient for the weight loss management. What are you expecting from the endocrinologist from the hepatology perspective? Can someone comment on that? Maybe Professor Swank or Swan? Maybe can give you our vision of how you would need to work with endocrinologists in your practice?
Yeah, thank you for the question. I'm lucky to have a long-standing collaboration in my institution with the diabetologists, and we're screening for them the patients that come for their annual checkup, which is an obligation in Belgium. But what we expect from diabetologists is indeed, first of all, have an eye on it and consider it as one of the complications to screen for, and it's not just the lowest one on the list, it's just like the other ones that needs to be on the same level. And on the other hand, we discuss a lot about treatment in patients that are more advanced. As you say, of course, as hepatologists, we think that we need to take care of the most advanced patients, and patients with just fatty liver, that's something that we cannot take care of and we should not take care of. But we like to interact on the more severe cases, and it's important to have some kind of conversation about the treatment that can be mutually effective. Some of the anti-diabetic treatments are highly effective also for NASH, and the other way around, also in the development of new treatments, we need to sit together and see what the ideal treatment is and the ideal journey for the patient is. So for me, it's really about interaction, although as Ken said, we're working sometimes in silos, but we need to collaborate and to have multidisciplinary approach, as we also have with other aspects of liver disease, and you have for other aspects of the problem. Of course, that can be a little bit time consuming, but if it's well organized, it can be done in an efficient way, I think.
Great, Sven. Over to you, Shira.
I wanted to add what, as a dietitian, I expect of you, the hepatologist and the epidologist. And I think it's really important to say that you are the most important people in terms of creating the motivation for lifestyle change among the patients. They listen to you. You are the highest authority. So I expect of you, of all of you actually, to discuss with the patients, to explain to them the importance of lifestyle modification, and to convince them, to create the motivations to start a lifestyle change. And then I expect you to do follow-up and to see how they succeed with their lifestyle modification, and to provide feedback for every positive change that they do. If they increase the physical activity, you should say, well done. And if they reduce sugar consumption, you should give them positive feedback, because your feedback is extremely important for this process of lifestyle modification. And another last point is to do repeated checks on liver status following significant lifestyle modification or significant weight reduction, because one of the things that encourage the patients to continue with lifestyle modifications is if they have repeated ultrasound or repeated fibroscan and they see the improvements with their own eyes. So this is really, really important to have the nutritional and lifestyle follow-up, and to send them to do repeated measures. So if they reduce, for example, 7% of their initial body weight, it is really helpful if they repeat the non-invasive test and they see the improvement. And of course, they hear it also from you. So thank you.
Yeah, I totally agree with you. I think we really need to work together to reinforce the motivation. And when you hear that you need to take care of your liver from your endocrinologist, then you need to you hear the same thing from your hepatologist, and then the dietitian is also helping. It's really nice to see that we can sometimes achieve very nice results in the management of the patient. Following on that, we have a question from Alina Allen. We know that sometimes there's a patient that we may not see, or as it's a silent disease, we may not be careful in the clinics that we should take care of the liver, or follow up on a previous test that has been made, and with an alert of potential elevated liver enzyme or FIB4, and do any one of you has used any electronic health system to bridge the gap between the disciplines? Meaning, if we could have a best practice alert for screening and clinical pathway implemented directly in our health system software, do you think that could be something that would help us to manage and to actually take a better care of the patient? Who has any experience of that? Any thoughts?
Go ahead. Manolis, you want to answer this in the context of the...
Okay, I mean, I can, if I understood the question correctly, the way it worked in our pathway was that once a patient was coded as having Nafld, then the FIB4 was automatically calculated. The GP did not have to do anything. And then the GP got a prompt in his or her mailbox that, it was like a traffic light system, that it's green, so it can stay with you, and the lifestyle advice that we have agreed, it is amber, so the patient needs an ELF test, and there was already stored serum that was sent without the patient being seen again, and read, please refer directly to hepatology. So we had an automatic calculation of the FIB4, and it worked quite well because it did not add to the already very heavy duties of the GPs.
I agree. This automated system could help. Kenneth, you have experience with that?
Yeah. So we have now put a FIB4 calculator. We have a number of calculations and put it in there. I mean, our primary care doctors don't want another alert because they have alerts for so many medical conditions that they just turn them off now. So that would be ideal, what Manolis is saying, but they have so many disease states that it creates difficulty. But they have a calculator, and then the result can be pasted into the electronic medical record. So that's a little step forward in this awareness campaign.
Okay, great. Now I saw one question coming on the preparedness of countries, and I know, Jeff, that you did some work around that and actually tried to define this. So maybe a quick answer or you take on the preparedness of health systems to tackle this interdisciplinary.
Thanks, Jörn. I mean, it's great to see so many disciplines and expertise represented in one place. So I wish this was what it looked like when countries were facing NAFLD, but when we went out and we analyzed this in 102 countries, and Manolis briefly presented it, a third of the countries scored 0 out of 100, and no country reported being well prepared in terms of having the right policies in place. So understanding the epidemiology, the economic consequences, having the right clinical guidelines, a whole range of indicators were presented to the countries, and they all essentially failed. It's true some countries did better than others, and they're very proud of that, but they still all failed. So there's an incredible amount of work for countries to do to prepare. That doesn't mean that we don't have the right clinical expertise in countries or enough of that expertise, but overall to address NAFLD, countries are simply not prepared from a public health perspective at this time.
Okay, thank you. I think we're almost at the end. There was one more question, maybe a quick comment, Robert, on the screening. You wanted to mention something here towards the end?
Okay, thank you. So just as we're talking about innovations and we're talking about the future and possibilities, being here in the UK and having just reached years old, I had my NHS letter that it was time for my MOT, my checkup. And I'm just wondering, is it possible to look at the possibility of, when we do a patient checkup, that actually a cheeky wee fibre scan or a cheeky wee check of liver health would be part of that? And how much would that save us in terms of cost? How much would that benefit in terms of patients being caught earlier? And how would that help liver clinicians around the world.
Thank you, Robert. And it's something that I heard through, throughout this discussion on multiple levels. I think with the improvement of NITs, we're really making big steps towards to define the target population we'd like to see at the hepatologist to be happy with the patients that are being referred and be able to offer something to patients and endocrinologists. So I think this has been a great round of discussion. We've touched so many topics in such a short time. It is a pleasure to say thank you to all of you who participated in this. Thank you in particular to you, Cyril, for sharing this with me. And thank you for all who listened and followed online. And with that, I'll hand it over to Jeff. Thank you.
Great. Thank you very much, Jörn. And let me echo your thanks to all of the participants, to the co-chairs, to our sponsors here, EchoSense, as well as to academic medical education for believing in this project and the importance of addressing innovations in fatty liver disease care. You see here a whole list of endorsers. We hope to grow this and to repeat this event. So please let us know if you'd like to endorse or be involved in other ways. Thank you to our media partners, Sage Publishing and the Surfing the Nash Tsunami podcast, which I hope everyone listens to every week. As mentioned earlier, your feedback's incredibly important. We're doing this because we've had input that it's important, but now we want to hear what you thought of this particular meeting, this webinar. So please do that after you send it. You can also get a certificate of attendance and CME credit. And finally, we do hope to see everyone in person. We're doing what we can to combat the COVID-19 pandemic so that you can join us in Barcelona on the 6th and 7th of May this year. It will be a hybrid workshop. We know it will be challenging for many people to travel, pandemic aside. We realize it's been a tough couple of years, but still we think it's time to come together again as a multidisciplinary group like you saw here on this webinar and discuss innovations in Nafld care. So you'll receive further information, watch us on Twitter, follow the academic medical education website, and we hope to see you all soon again. So for that conference, you can also submit an abstract. You see the categories here on the left. There's a deadline at the end of February. And if you're quick, you can scan the code and get all of that information, or again, just go onto the academic medical education website. And that concludes this event. Thank you, Jörn, for co-chairing and organizing this with me. And thank you all again. Have a good rest of the day.
Take care. Thank you.